So I thank the organizers for giving this opportunity. Topic for me is on gastric and esophageal malignancy, how to optimize the treatment and survival of these patients in both HER2 positive as well as negative disease. So my topic is divided into those with curable malignancies and those where we are treating with palliative intent. Under curable malignancies, the first thing I would like to discuss is the role of chemotherapy versus chemoradiation, because over a period of time, chemoradiation has established itself as the neoadjuvant treatment of choice. So there were two trials which I need to discuss. One is the NeoAegis trial. This started a little bit backwards, but however, in 2018, they did an amendment. So what was this trial? They took patients with adenocarcinoma of the esophagus and gastroesophageal junction. They gave the classical cross regimen of chemoradiation followed by surgery, and they randomized it between this group versus the surgery with the perioperative chemotherapy, which is a classical in Europe. In 2018, they modified it, amended it, and added FLOT regimen, which by then had become the treatment of choice. Also, they amended it from a superiority trial to a non-inferiority trial. So what did it show? Absolutely no difference between chemoradiation and perioperative chemotherapy in patients with adenocarcinoma of the esophagus and GE junction. So what about squamous cell carcinoma? Now this paper was presented few days back at the ASCO GI symposium, where they took patients with esophageal squamous cell carcinoma. This is a Japanese trial, and they randomized it between their standard neoadjuvant chemotherapy of cisplatin 5-FU versus neoadjuvant DCF, which they thought is better, or neoadjuvant CRT with 5-FU cisplatin and radiation, and then took up these patients for surgery. Mind you, it was all D2 dissection. What did it show? When they used DCF and compared it with CF, there was a definite benefit of adding docetaxel with a hazard ratio of 0.68. However, there was no difference when you tried to give chemoradiation compared to cisplatin 5-FU alone. So this trial, what did it show was neoadjuvant DCF, but not neoadjuvant CTRT, significantly improved the overall survival compared to neoadjuvant chemotherapy with cisplatin 5-FU with locally for patients with locally advanced squamous cell carcinoma of the esophagus. And they suggested neoadjuvant DCF is a new standard of treatment. So both in adenocarcinoma in this trial, it seems to be that neoadjuvant chemoradiation is gradually moving or shifting towards neoadjuvant or perioperative chemotherapy. So the next topic is adjuvant immunotherapy. Now this has been discussed extensively. This is the Checkmate 577 trial, where they took patients with locally advanced squamous cell as well as adenocarcinoma, took these patients up for the classical chemoradiation protocol, neoadjuvant, followed by surgery, and then randomized to using giving nivolumab or placebo. Mind you, this was only in patients who had residual pathological disease either in the lymph node or in the primary tumor. So this was presented in 2020 and updated last year in ASCO 2021. In 2020 in ESMO, they showed that there is a doubling of the DFS from 11 months to 22 months. And now when they updated, they found that the DFS continues to remain beneficial for nivolumab. However, they also showed significant benefit in terms of distant metastasis-free survival. You can see the hazard ratio, as also in terms of PFS2. The quality of life also was significantly good in these patients, suggesting that nivolumab does not harm these patients. So, in patients with squamous cell carcinoma and adenocarcinoma, post CTRT and surgery, nivolumab is now the standard of care. But what about patients who are now being shifted towards the neoadjuvant chemotherapy protocol? There is a trial going on called the Keynote 585, where they are trying to use perioperative pembrolizumab along with chemotherapy. And also, what about patients who now are being treated with definitive chemoradiation and surgery is not being done? So there also a trial is going on, the Keynote 975. There is also a trial in patients who are MSI high, where they are trying to eliminate chemotherapy and use only neoadjuvant nivolumab, surgery followed by adjuvant nivolumab. This was presented 5 days back in ASCO GI symposium. And what did they show? 59% pathological CR in these patients with MSI high. We know that MSI high patients do very well with immunotherapy, but are we looking at a future where patients with MSII do not get chemotherapy at all, and we give them a chemotherapy free neoadjuvant and adjuvant treatment with immunotherapy? So, adjuvant immunotherapy is standard of care for patients who have residual disease after surgery and who have received neoadjuvant CTRT. All other instances are being developed. What about use of anti-HER2 therapy in the curable setting? This was just 1.5, 2 years back in ASCO 2020, where they presented the RTOG 1010 trial, classical trimodality therapy compared to trimodality therapy with the addition of trastuzumab. It was negative in terms of PCR. There was no difference in PCR, in terms of disease-free survival, and also in terms of overall survival. So adding adjuvant or adjuvant trastuzumab has no role. There is an ongoing trial called the innovation trial, where they are trying to use not only trastuzumab but also pertuzumab in this curable setting. But at present, there is no role for anti-HER2 therapy either as adjuvant or neoadjuvant. Now coming to the palliative setting, the role of anti-HER2. Anti-HER2 therapy has evolved. The TOGA trial established trastuzumab as the first-line agent along with chemotherapy in patients with HER2 positive gastric cancer. However, lapatinib logic trial failed, as also the use of pertuzumab in first line in the Jacob trial. Also in second line, continuation of trastuzumab in the TAC study, as well as the use of TDM1 did not prove to be beneficial. In this background, the Destiny Gastric 1 trial was conducted mainly in Asia, that is Japan and Korea, where patients who have metastatic esophageal gastric junction cancer who have progressed on more than 2 prior regimens received either trastuzumab deruxtecan or the physician's choice of chemotherapy. It showed excellent response rate of 51% with the trastuzumab deruxtecan compared with 14% of patients who responded when given chemotherapy. Also, there was significant benefit in terms of PFS and OS. Now, this was done basically in Japanese and Korean patients, but based on this, FDA gave the approval for this drug. However, in the Western country, Gastric 02 Destiny trial was done to evaluate this drug in the Western population. The only difference was, one, patients received it after progressing on first line, unlike the previous trial where it was only after the second line. And also in these patients, they did a repeat biopsy to ensure that the tumors are still HER2 positive, because there were some studies which indicated up to 30% of patients who progressed on trastuzumab tend to lose the HER2 expression. Now, there was a good response rate of around 38% and good improvement in terms of PFS also, suggesting that this drug works as well as in the Western population as it does in the Asians. The updated median overall survival presented in ESMO 2021 also was consistent with beneficial with trastuzumab deruxtecan. So, in the palliative second line setting, anti-HER2 therapy, trastuzumab deruxtecan is now become the standard choice. Finally, what about immunotherapy? Now, I will just put in first into metastatic squamous cell carcinoma of the esophagus with the Checkmate 648 trial, where they compared chemotherapy versus Nivo plus chemo and Nivo plus ipilimumab. Now, these patients were in squamous cell carcinoma, and what did it show? This is a primary endpoint, that is overall survival in patients with PDL1 more than 1%, significant benefit with Nivo plus chemotherapy, and this benefit extended to the entire population, but with little bit less benefit. Also, there was benefit with Nivo EP in both the PDL1 positive as well as in the entire population, but the benefit is slightly less. You can see the hazard ratio 0.64 compared to 0.54 with Nivo plus chemo. So Nivo plus chemo seems to be better. When you looked at the progression-free survival, patients with Nivo plus chemotherapy, significant benefit you can see compared to Nivo EP as well as those receiving chemo alone. So when you look at PFS, the Nivo ipilimumab arm comes down a little bit when you compare it with Nivo and chemotherapy. When you look at the response rate also, Nivo plus chemotherapy wins hands down with 53% response rate compared to 35 and 20% in patients getting Nivo plus EP and chemo in the PDL1 positive patient. And this benefit seems to be there even in all randomized patients. So this trial concluded that there was significant overall survival benefit, also significant benefit with progression-free survival and response rate when you gave Nivo plus chemotherapy. There was only overall survival benefit when you gave Nivo plus ipilimumab. Similar trial in adenocarcinoma, what did it show? The Checkmate 649. It showed significant benefit for patients with CPS score more than 5 when you gave Nivo plus chemotherapy compared to chemotherapy alone. And when the patients were MSI high, there was lot of benefit not only with chemotherapy and nivolumab, but also nivolumab plus ipilimumab. You can see the hazard ratio for MSI patients is 0.38 compared to chemo alone and 0.28 when you compare nivo-ipi with chemotherapy alone. MSI on its own significantly tells us that these patients will benefit from immunotherapy. What about nivo-ipi in adenocarcinoma in 649? Nivo-ipi in adenocarcinoma does not show progression-free survival benefit, nor does it show overall survival benefit. You can see it clearly that the overall survival, even when the CPS score is more than 5, is 11.2 versus 11.6, and PFS, of course, is 2.8 compared to 6.3. So in this trial, what it showed is Nivo chemotherapy significantly improves PFS and overall survival and response rates, whereas Nivo plus ipilimumab is not good even when you select patients with CPS more than 5. What about pembrolizumab? This was presented 2 years back in 2020, but it has been updated 4 days back in the ESMO GI meeting. This also was very similar to the Checkmate, where here they used patients with both adenocarcinoma as well as squamous cell carcinoma, compared placebo to pembrolizumab along with chemotherapy, and there was significant benefit in PFS in virtually all patients and overall survival benefit, even though the benefit seemed to be little more in patients with squamous cell carcinoma. And probably the only group of patients who didn't respond that well were those patients with CPS score less than 10. Related presentation, where I have not got my hands on the presentation, just 4 days back, continued to show first-line pembrolizumab plus chemotherapy significant benefit in patients with adenocarcinoma across all subgroups in this trial. So what about adding immunotherapy to trastuzumab and chemotherapy? And combination, that is chemotherapy, immunotherapy, and anti-HER2 therapy. This Keynote 811 trial was presented at ASCO 2021. This is in patients with adenocarcinoma, and the primary endpoint was OS and PFS. Now, what did it show? The overall response rate is significantly better compared to placebo when you gave pembrolizumab from 52% to 74%. The chances that the patient will have CR and PR is much more with pembrolizumab, and stable disease is much more with placebo. The duration of response and the depth of response is also better with pembrolizumab. So actually pembrolizumab in this combination has been approved, and it seems that immunotherapy is useful in virtually most of these patients. So which are those patients wherein you will not give immunotherapy as first line in metastatic esophagogastric junction? Probably this is the only group, that is patients with adenocarcinoma with a CPS score between 0 to 4 are probably the only group who have no benefit from using immunotherapy. Virtually everybody has got very good response. Overall survival benefit shown in all the groups, except overall survival is still immature in this group where you combine it with trastuzumab and chemotherapy. So with that, I would like to conclude saying, in patients with curable malignancy, I think we are moving towards neoadjuvant and adjuvant chemotherapy rather than the standard neoadjuvant chemoradiation. In terms of adjuvant immunotherapy, it is now the standard when patients have residual disease post-operative, especially if they have received neoadjuvant chemoradiation before. There is no role for using anti-HER2 therapy in a curable setting. In the palliative setting, trastuzumab deruxtecan has established itself in second line and beyond, and immunotherapy is now being used in virtually most patients with metastatic esophagogastric junction. With that, I thank you for your patient listening. Thanks a lot.